Thank you so much. First of all, let me thank Professor Sanicola for his kind invitation, as well as for the cooperation that he's always shown with my son, Angelo. Usually, we begin a presentation by saying, Mr. President, but it sounds to me a bit difficult to do so here. So let's move on from the pterygium we have just heard about. And let's see that today we classify under this term ocular surface squamous neoplasias or neoplasms a number of different conditions that in the past were classified differently or named differently. It might be useful to continue separate them, especially to separate and distinguish them from the invasive carcinoma. It's the carcinoma is the most common ocular surface cancer with a higher incidence in males, Caucasians, with a history of ultraviolet light exposure. Here you may see the average age. It doesn't often occur in young patients unless there is an HIV history. And the papillomavirus has also been implied in the carcinogenesis. This is how in 2014 the onset of the cancer was explained. So first of all, UV radiation, so the DNA damage from UV radiation. And we have the reactivation of latent viruses, immunosuppression, and then it all happens in a nasal limbus, where the crypts include niches of stem cells, which are the progenitor cells of the tumor. Here you can see this classification, which is extremely recent. It's only 3 years ago. And we have another one dating back to 1973, a paper that I have actually developed with the late Professor Cardia. So if you take a look at the two cancer formation diagrams, already back in 1973, although we didn't have a very clear idea of limbus stem cells, more or less we said the same things. So the only problem was that probably we published this paper in Italian, even though I already started publishing on foreign journals in the 70s. But I wanted to show you this in memory of Professor Cardia. So clinical features, it is sessile, fleshy, elevated lesion adjacent and interpalpebral region. I wish to draw your attention onto these kinds of lesions, which are the most dangerous ones, but luckily enough, less frequent ones as well. Because as long as we have these plaque-like lesions, I can tell you on the basis of my experience that the prognosis is much more favorable, whereas I think we should be much more worried in terms of recurrences when we have papilloma-like lesions that might start at the nasal level, but then that might diffuse as recurrences on in all other regions. Less frequent, the location of the tarsal conjunctiva, inferior pharynx, and caruncle. At a slit lamp, we can already see some of the most important features of these lesions, but unfortunately, the OCT of the inferior segment doesn't provide us with very significant information, especially when it comes to the invasiveness within the stroma basal membrane. So confocal microscopy can give us quite a significant but superficial impression cytology, can only tell us something about superficial cells. Confocal microscopy is a bit better, but biopsy is the only exam that can really identify how to classify the invasive squamous carcinoma. So diagnosis. Perhaps it would be better, considering that when we have to make reference to pathological diagnosis, to forget this umbrella term, and we should better talk about if we want to have a diagnosis for treatment, simple dysplasia in situ carcinoma, or even squamous invasive carcinoma, which means that the tumor has crossed the basal membrane and has penetrated into the substantia propria. Also here we have a TNM classification or staging that has to do with the primary tumor or far metastases, which unfortunately, fortunately, aren't that frequent. Although it isn't unlikely that in a papilloma-like lesions, even the visual function might get lost should there be many recurrences. Surgical excision, it has been the treatment of choice for many years, but you may see that recurrences are quite frequent, especially in terms of positive margins. So there might be, as an outcome, a limbal deficit, symblepharon, and the chemo drugs or immuno drugs topically have been often used, especially in combination with surgery, so mitomycin C5 fluo, and especially recently interferon alpha 2b. With these drugs, we can treat the whole ocular surface and slightly reduce surgical risk. So over the years, as you may see here, the combined utilization of chemotherapy plus topical immunotherapy has exponentially grown, and the full response, so full healing, has considerably improved ever since these substances started to be used, in particular interferon. This is a case series of ours from the Gemelli Hospital and the department chaired by Professor Blasi. So we have quite an important case series. As you may see, these are the features of our cases. We have T2 and T3 cases, all of them N0 and N2. So the excision and the cryotherapy of the conjunctival margin, the scleral bed. But here some words, some caveats are necessary, because as long as we get to the cornea, the cancer cells just slide on the membrane layer, because this is an impenetrable barrier for cancer cells. But this is not true of conjunctival stroma. So if a cryotherapy is performed generously, and I don't like to do it on the cornea, we might damage the Baumann layer and therefore also favor the corneal invasion. So I use it in a very discreet way, especially on the conjunctival aspect. So mitomycin 3 times a day for weeks, IFN 9 millions. I use subconjunctival injections per month, 6 months duration. As you might see from these tables, the recurrency rates really dropped dramatically since we combined chemotherapy to surgery, but especially immunotherapy, a-specific interferon immunotherapy. As I was saying, these used to be clinical impressions, and I insist on this continuously, because one shouldn't only trust the literature god, because the literature states that and this. So clinical literature data have to be checked. So the fact that the papilloma-like lesions had a greater recurrency rate, probably, this has been already had been already established several years ago. But eventually, these impressions were corroborated by literature data. So in conclusions, and I'm done. In our practice, the squamous neoplasia of the ocular surface shouldn't be today treated with a simple excision. It is very useful to also apply topical adjuvant chemotherapy and subconjunctival interferon injections proved to be more efficacious than mitomycin to prevent recurrences. An early diagnosis, an early treatment can decrease the risk of a locally aggressive disease, improve the patient's diagnosis and local control, as well as preserving the visual acuity or the vision of these patients, which is, after all, the most important thing you should have in mind. Since no single treatment proved to be superior in terms of recurrency rates, we have to monitor closely these cases and conclude that the combination of treatments is always the best way to go in terms of the course of the disease.